Hello everyone. Next, let's talk something about the treatment and prognosis of pulmonary thromboembolism. As for the treatment of pulmonary thromboembolism, basically we have two types of treatment, that is anticoagulation and thrombolysis. And if the patient have contraindication for anticoagulation and or thrombolysis, they may accept intervention treatment or even surgery. But most patients, they need anticoagulation or thrombolysis. Here's a flow chart to tell us what type of patients may need thrombolysis and what type of patients may need anticoagulation. Actually, we can say all the patients, if they don't have contraindications for anticoagulation, actually all the pulmonary thromboembolism patients, they may need anticoagulation. But some of them, especially those with shock or hypertension, which means they have hemodynamic instability and classified as high-risk patients, they need primary reperfusion, that is thrombolysis. And for those don't have shock or hypertension, that means they are hemodynamically stable, we can do the PSI scoring, and we can do the lab tests, and we can do the echocardiography to evaluate patients' right ventricle function. If patient's right ventricle function is bad, which means patients are intermediate high risk or intermediate low risk, then we need to think about it. If the patient need reperfusion or patient just need anticoagulation. And for those who are of low risk, we just give them anticoagulation. We have many anticoagulation drugs like heparin, actually unfractionated heparin, and we have enoxaparin, we have dalteparin, tinzaparin, and these three drugs are actually low molecular weight heparin. They have better safety profiles. I mean, patients with low molecular weight heparin, they have less smaller chance to have bleeding, and we have fondaparinux, and we have oral anticoagulations like rivaroxaban, like apixaban, and of course we have warfarin, which is a vitamin K antagonist. For warfarin, usually the Eurostat dose is 5 mg, and we need to monitor patients' blood tests, patients' INR, which is international ratio, to a target range that is 2 to 3. And for thrombolysis, we usually have 3 generations of thrombolytics. The first generation is streptokinase and urokinase. Second generation of thrombolytic is L-teplase. And the third generation of thrombolytic is red plates and tenector plates. And these three generations of thrombolytics, they can help patients to reperfuse their pulmonary vasculature. For the prognosis of pulmonary thromboembolism, those with high risk, those high risk PE patients, there is a good chance the patient may die of cardiovascular compromise, and especially those without effective treatment. And with effective treatment, most patients can fully recover. But some patients may develop chronic thromboembolic pulmonary hypertension. And for those with DVT, some may develop post-thrombotic syndrome. What is post-thrombotic syndrome? It is also known as chronic venous insufficiency. Patients have damage of their venous valves of the leg and have ankle or leg swelling and leg aching. Some may even have skin ulceration. This picture is a typical post-thrombotic syndrome. You can see the necrosis is very prominent, and also you can see the swelling of the leg and ankle and the pigmentation because of the chronic ischemia of the lower extremity. And here's another picture for post-thrombotic syndrome. And that's all for the treatment and prognosis of pulmonary thromboembolies and DVT.